and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I am Gina Choi, and I'm here with Chanda and Marina Serper to discuss their recent publication on a practical approach to starting a telemedicine program. Welcome. Thank you so much for joining us today. I'd like to start off by asking Dr. Serper, what were some initial challenges your center went through when starting your telemedicine program?
So thank you for asking, Dr. Choi. Our biggest challenge was that we actually had a pre-existing telehealth infrastructure, and we were able to deliver maybe about 100 telehealth visits per day with a specific vendor. And this was for smaller programs like telegenetics, teleneurology, and a little bit for research purposes. However, given the pandemic, we had to scale that completely and shift essentially 70% of our outpatient practices to telehealth. And so our vendor was not actually able to support the volume. And so technically the system kept crashing. And so very, very quickly, within about less than a week, we realized, actually within a couple of days, we realized that that vendor could not support what we were doing. We actually had to rapidly find another vendor and just deploy a completely different system and a different software. And so the unique thing that happened was our medical students were sent home with the shelter in place orders. And so we actually had a small army of medical student volunteers that actually helped with the tech support and helped the practitioners and the patients download the new software vendor, and really helped us build out the telehealth program. But we had to completely pivot vendors within just a couple of days.
That's fantastic. In your paper, you talk about the digital divide. Do you have any solutions for patients who are perhaps not as proficient in technology, or older patients, or even people who have limited English abilities?
Yeah, so there are a couple of things that were key takeaways for us. And I think Penn is actually probably at the forefront of how to deliver telehealth and some of telehealth's best practices. So again, early on, we realized that coordinating scheduling of appointments with patients often kind of fell by the wayside. People were not familiar with telehealth, the front desk staff or the patients. So our health system actually developed something that we call the switchboard, which is a standalone kind of wraparound, we call it, a platform that interfaces with our EHR, which is Epic. And actually, you are able to see the patient's schedule in that standalone platform. It automatically sends text messages to the patients and allows them to click on a link to be able to join their visit. So that really helps. The other thing that helps us with limited English proficiency, we actually built in integrated translation services. So there are a variety of languages where translation is automated in terms of the language, the text message that gets sent to a patient's phone to join their visit, or an email, by the way. And also we're now able to have third-party connections where a patient's family member and a translator are able to join the visit. So that really helps.
Oh, wow.
In terms of not being very well versed or computer literate, we noted that initially we had some patients had struggles because they had to download a standalone app for our vendor and have maybe a username and login. So we found that removing that barrier really helps. So just simply sending a patient a text via email and a text on their phone and via email with a direct click was very helpful. And Doximity, just to talk about specific vendors, also has that function. And so removing the need for username, for a password, the need to download an existing software really helps patients be able to connect very quickly.
I see. Our institution also has Epic, and it's very confusing because it only works on their phone, and they try to log in on their computer. Mm-hmm. And so we have all these difficulties with that, but those are great answers. Thank you.
And one other thing I want to mention is there are a lot of redundancy built in, and some people may find it challenging. Some patients maybe find it annoying, but there are redundancies where there's a pre-visit guide that's sent via email and text at the scheduled visit 3 days before and 10 minutes before the visit with instructions on how to log in. So that also helps with the connection.
That's great. Dr. Ho, what type of visits do you think are best suited for telehealth?
Thanks, Dr. Choi. Thanks for having us. In terms of visits best suited for telehealth and telehepatology, I think, this experience that we've had with telemedicine during the pandemic has proven that the vast majority of hepatology visits can be done through telemedicine. We're seeing still at this point, over half of our visits, even with COVID being better controlled, are still televisits, in part due to wanting to reduce kind of spread of COVID, but also patient preference. And that's something that we're seeing, that patients are demanding televisits now that they've been able to experience it. But bread and butter hepatology, viral hepatitis, I've treated, initiated treatment on Hep B, Hep C without having to see the patients in person. Elevated LFTs, NAFLD, NASH, alcohol-related liver disease. During the height of the pandemic, mostly in 2020, we did perform a lot of evals remotely, but based on kind of our center's experience, once COVID got under better control, we actually preferred that patients come in person, in part because you want to understand compliance with a medical center for, transplant listing and stuff like that, but it can be done. We've shown that we can do it successfully. We were able to eval a large number of patients and get them listed and still maintain our transplant volume during 2020, which was, I think pretty surprising, because once shelter in place went in March and we looked at our numbers at the end of the year, we maintained our transplant volume in 2020 with a lot of the visits being remote.
That's great proof that it works. Was anybody against that, or was everybody on board with that? I'm sure the patients were thinking, yay, no traffic, because I know you practice in San Francisco, so traffic is real.
Patients really, really liked it. I mean, I think the burden of, being in a big city and San Francisco being, obviously having a really high cost of living, most of our patients, even though we're based in San Francisco, actually live outside of the city. And they travel, sometimes 1 to 2 to multiple hours in. So our footprint is not only the Bay Area, but mostly the footprint of Northern California. Something that makes, I think, CPMC stand out is that we have a large number of outreach satellite locations. So pre-pandemic, our doctors and nurse practitioners were actually traveling physically to areas, north as Eureka, California. We have one physician who actually goes to Nevada as well to practice. So we have a pretty big catchment area, with Sutter Health kind of being our parent organization, being centered in Sacramento. So a lot of Northern California patients. And so that was interesting because the doctors actually didn't have to travel to the satellite clinics because, COVID was pretty out of control, last year. And patients actually really liked it. They liked the, convenience of having a televisit. There were kind of those initial growing pains of kind of getting the patient set up with, the technology. And, we could not have done it without our medical assistants. They really did the vast majority of the patient prep. So, for us, we choose a platform, whether it was the EHR platform through Epic, kind of with the current waivers, we're able to use things like Zoom and WebEx. So we're able to kind of, we start the video and we, unmute ourselves. But there was so much prep work that the MAs had to do with the patients to understand, okay, basic stuff. Do you have an internet connection? Do you have Wi-Fi? What type of phone do you have? And so they spent a lot of time, but once that kind of got established, I think that really, the patients really did enjoy having that flexibility.
Right. Were there any surprising side effects associated with the wider implementation of telehealth that you didn't anticipate that came up?
I guess looking back, I think there are some kind of positive and maybe not as positive side effects. Positive ones, kind of what we just talked about with patients, loving, telemedicine and having the convenience of, I didn't have to drive 3 hours for you to tell me that, my labs looked okay and that I should get, another ultrasound and labs and my endoscopy done. So a lot of that can be done remotely. And so we've seen kind of an increased demand, and it'll be interesting to see what happens once COVID kind of is less of an issue, right? In terms of when the emergency declaration goes away and when these waivers go away, what happens to the future of telehealth? But the patients do want it. And then, when I'm kind of closing out, summarizing our visit, they're like, can our next visit be remote? And I'm like, okay, yeah, it can be. The other thing is, I think that's really opened up doors in terms of technology. I think some patients, if they weren't kind of forced to use telehealth in order to kind of maintain their relationship with their doctors, some of them wouldn't have ever used, these platforms if it weren't for the pandemic. I mean, I say that just because one story comes to mind where I was using a group, Zoom or a group FaceTime with a patient, and they're like, I really want to say that this has really changed. I mean, it was just one patient, but he said it changed his life because he was able to connect with family members who live far away that he, didn't know how to connect with unless he was kind of forced to do it for the doctor's visit. So that's a positive thing. One other potential side effect is, we've seen this huge volume, right? Because a lot of the televisits happen through our EHR platform. And so one of the prerequisites is that the patients have to be logged in through the patient portal. And so we're seeing an increase in the number of, patient portal messages, which is a strain on the system, just because that was in the pre-COVID infrastructure that wasn't there. And so we're trying to think of ways that we can have more support to help triage patient messages, patient requests, and perhaps looking into having more MAs to kind of support our clinical operations.
That's outstanding. That's outstanding. To both of you, what do you think will be the future of telehepatology? You kind of both alluded to it a little bit, but just as a final, where do you see this integrated into our practice in the future, and how so?
I think a lot will be driven by reimbursement. And I think just to be brief, I think we have a ways to go to figure out how to integrate telehepatology into routine practice. Reimbursement regulation is going to play a role. With Medicare, some hospital-based practices, there's a facility fee that is able to be billed with Medicare and some other private payers that the hospital may be missing out on with telehealth, even with parity in reimbursement. And some of the parity may go away in the future. So we really need to think about that aspect. And the second aspect is, can you establish a relationship with a patient if you've never met them in person? Is that relationship as strong? How can you follow decompensated patients? What's the right dose of telehealth?
Right. How do you weigh them on telehealth? Right.
Yeah.
Dr. Ho, do you have any additional thoughts?
Yeah, I agree with Dr. Serper. I mean, I think those are really important points. I think one of the reasons, we weren't able to get a telehealth program set up prior to the pandemic was for those reasons that she mentioned. Reimbursement and regulation were always the reasons of, those are the main barriers why we can get it set up. But, with COVID, we were able to do that. But yes, what happens once, hopefully, COVID goes away or COVID becomes more endemic? So definitely those are issues to think about. I think it'll be important to kind of pull together our collective experience in terms to advocate kind of for our patients, because there will come a time where probably these waivers will go away and we'll have to go back to where we were. But I have a feeling that we won't go quite back to square one, especially with all the, I think, positive side effects of telehepatology. But again, you do have to be careful, as Dr. Serper alluded to, is, what is the right amount? There are some challenges, right? When you've never met them in person and, you kind of see them from here on, from here up. Obviously you try to do your best with an exam, but, obviously it's not quite the same as meeting them in person and having that rapport and just kind of having that kind of relationship with the patient that, unfortunately a screen can't replace.
Right, absolutely. Well, thank you so much for your input. Thank you so much for your insight. It's such a privilege to talk to two trailblazers, one on the East Coast in Pennsylvania, one on the West Coast in San Francisco. I hope you have a great day, and thank you again.
Thank you very much for having us.
Thanks. Thanks,
Bye-bye.
Dr. Choi.
Thank you.
Bye.